So we used to think it was just a disease of mechanics. And we thought that it wasn't inflammatory because there were no neutrophils in the synovium or in the synovial fluid or in the synovial membranes. We thought it was just bad biomechanics. So that's not how we think about it anymore. It's much more than that. Although certainly bad biomechanics plays a role. But there's lots of things that play a role. Obesity, which changes mechanics, and that's a huge problem across the world. Inactivity, stillness turns out to be really bad for you. Overactivity can be bad. We don't work people to death anymore in this country, but I'm sure there are countries where people get worked to death. Trauma, particularly if it crosses a joint or tears a tendon, where you lose the biomechanical integrity. Poor nutrition. I mean, this is, as living organisms, we have to put in the things that help us rebuild our bodies because we're always tearing it down. For instance, bone turns over completely every 10 years. It's not just your hair grows and you cut it off, your skin turns over every month, your bones every 10 years. So if you don't nourish those cells so they can eat while you're sitting still, your joints aren't going to last.
Welcome to another episode of the Capital Integrative Health Podcast. I'm your host, Dr. Andrew Wong, and today we're bringing you a great conversation with Dr. Carla Guggenheim, a board-certified rheumatologist, Southern Indian dancer, Laban movement analyst, and scientist. This conversation is about root causes of osteoarthritis, which we know affects millions of people worldwide, and Dr. Guggenheim's personal health journey. Osteoarthritis is a prevalent and debilitating condition that affects millions of people worldwide that causes joint pain, stiffness, and reduced mobility and quality of life. In this episode, we'll delve into the complexity of osteoarthritis, exploring its underlying causes and innovative treatment approaches. Dr. Carla Guggenheim brings a wealth of experience and a compassionate approach to the conversation. Whether you're personally affected by osteoarthritis or interested in learning more about this prevalent condition, please join us for a thought-provoking discussion with Dr. Carla on osteoarthritis and the holistic path to improve joint health. Welcome, Dr. Carla, to the podcast. Thanks so much for coming on today.
Oh, you're welcome. It's good to be here. Thank you.
So Dr. Carla Guggenheim, a functional medicine practitioner, and an expert in osteoarthritis, which is what we'll talk about today. But before we do that, we'd like to just kind of start by, if you could tell our listeners a bit about what drew you to become a doctor and then a functional medicine practitioner, and what do you enjoy most about what you do?
Oh, wow. I come from a very dysfunctional, drug-addicted family, and I danced. My mother dropped me off at the dance school. So dancing was my life, and all I ever wanted to be was ballerina. And I'm a third generation physician, but I never expected to do medicine. Never wanted to. I did help my dad back in his office back in the day when a 12-year-old could go into an ENT office and set up Pretz treatments and plate Petri dishes with snot and run the autoclave. And I did eye testing and I did hearing testing in his office as a tween and a teen.
Did he pay you, or was
No,
it,
no, I was just helping Dad.
helping out? Yeah.
And I was the San Francisco Ballet when I was 16, and I really they told me I could have a scholarship for the year. I was going to drop out of high school, and so I called my parents up. I said, I'm dropping out of high school. I'm I'm going to stay at the San Francisco Ballet. And they said, how will you pay rent? And I said, you will send me money. And they said, no. That's why I graduated from high school. I wasn't
Got
going to
it.
do that. But my contract weight is 110, and I was 5'4.5". I mean, not 110. My contract weight was 100, and I was 5'4.5". So, and I was solid muscle. And so I never really had anorexia. I was hungry, but I didn't eat. Whatever. I really liked San Francisco. So, and then after high school, I married really poorly, and that was brief. And then I started studying it. I went to New York to seek my fame and fortune, which didn't exactly work out, but I met a dance style called Bharatanatyam, which is from South India, and just fell in love with it. I started doing Bharatanatyam in 1971 or 72. And that was just really fun. I studied art and architecture at NYU. I studied aesthetics at Columbia Barnard. I mean, I was like in a candy store. It was so fun. I'm not sure why. I mean, that's not my heritage, but I love it. It's not cultural appropriation. It's cultural love. I'm in love with South India. So, and then at a certain point, like, you got to get a job. So, like a real job. I also did dance notation, but so I got a job teaching dance and dance history at Sonoma State in California, and married again disastrously, but briefly. And I took science courses in the mornings because I didn't have enough to do, and I liked science. And I got a degree, and when my marriage fell apart, I went to a friend of mine in the chemistry department. I said, I don't know what to do with my life. And he goes, well, you have A's in all the pre-med classes. Why don't you go to med school? I mean, I'd taken all kind of embryology, calculus, whatever.
Yeah.
I was pretty depressed, and I thought, well, that sounds like a good idea. And I applied and got in. So,
And the rest is history. So just
yeah, the rest is history. But I went to a DO school, and I kind of got through DO school, and I thought, I don't know how much I like this, So I had decided to do a really wonderful program at Michigan State University here that combined manual medicine with a master's degree in bioengineering. And I really like bioengineering. So I worked, so in the middle of my rotating internship, that program died and went to heaven, and I had to do something else. So I did internal medicine because they were the nicest, smartest people in town. That's how I picked it. And I think when you're picking residencies, you shouldn't go, oh, I'm going to be a neurosurgeon and make a lot of whatever. You should pick it with people that you like and the kind of life you want to have. Like, do you like short stories, work in the ER? You like long stories, go into rheumatology. So,
well, I'm an internal medicine doctor, so I feel like a piece of buttered bread now, but thank you for talking up internal medicine.
Yeah, my view of medicine's changed pretty drastically.
Yeah. I'm kind of curious how you have combined. I mean, we can get into this here on our podcast episode today with you, Carla, but how you've combined your love of South Indian dance, and I know you have the Taj Mahal of books behind you, the collection of dance books with medicine. How do you combine those two passions of yours?
Well, one of my colleagues at the University of Iowa, I used to go all over Eastern Iowa doing outreach clinics in rheumatology, and he was Indian, and he came to one of my performances that we did in this little town that he was in, and he said, I get it. Medicine's your hobby.
Yeah, that's very perceptive. Yeah, yeah.
Yeah, he said, "You're just doing this." I said, "Pretty much." I mean, although I did like rheumatology. I like rheumatology. Part of the reason I liked rheumatology was because I thought, most of this is total in my ignorance as an internist, most of these diseases are self-imposed. Like I got done with internal medicine residency, people smoked, drank, ate crap, were massively overweight and sat around and watched TV. And I thought, oh my God, I'm gonna I'm gonna see these people all day long.
And
And
that
I'm
was that was before Netflix, right? And now you
yeah,
can binge watch stuff, right?
yeah.
Yeah.
And I thought, I'm gonna give these people drugs for this
For self-imposed, yeah, or lifestyle, basically lifestyle issues that could be
lifestyle
reversed with lifestyle
disease.
change. Yeah, yeah.
Yeah. And I thought, I just don't see this. So I went to my director, who was wonderful. I said, Pat, I can't do this. I can't do this. I don't know what to do. I'd finished the work for my master's degree in bioengineering. But he said, well, why don't you apply to rheumatology? And they'd probably support your research. So I went, whoa, that's great. So that's what I did. And I went to the University of Iowa and I did rheumatology at the University of Iowa. And fortunately, there was an incredible artist who lived 2 doors away from me from South India who was amazing. So I danced. I thought, I'm going to Iowa. And, you know, so I also reconstruct French Baroque dance manuscripts, and I love French Baroque dance, although it comes out of a horrible culture of Louis XIV. But anyway, uh, I um, I danced with the Baroque orchestra. So like on the weekends, I was dancing with the Baroque orchestra,
So
going
cool. Yeah, so you're
bringing new,
practicing medicine, you're doing dance as well,
yeah.
dancing. And then how did you get into functional medicine, or what was the entry there?
My daughter went to naturopathic school in 2003.
Was that Portland or
Yeah, she went to the Portland school.
yeah,
She went to the Portland school, and she'd gone to Reed, and they don't have great inflation, and she couldn't. Anyway, she was very drawn to naturopathic medicine,
yeah,
and so she went there, and she would come back to Michigan for vacations and visits and whatever, and hang out in the clinic. And very perceptive, she would say, Mom, I don't think your patients really understand what you tell them. You're using, your words are too big. Oh. I said, well, why don't you study it? Why don't you sit down with patients? I always gave them a copy of their note. This is before, you know, EMRs were.
EMR, yeah.
So I'd give them a copy of your note. So she would take them in a room and say, what did Dr. Guggenheim tell you had? And uh, they'd say, I don't know. What medicines did she put you on? Uh, how are, what, and oh, and she'd say, well, you can look at your note and read it. Oh, I forgot my glasses today. 15% of those patients were illiterate.
Hmm.
The illiteracy rate here is pretty high.
Yeah, so can't assume that people are on that grade level to read the note.
Right.
Yeah,
And
that's true.
I took Medicaid, so um, and I worked for myself because I'm allergic to perfume. So the patients couldn't wear perfume, the staff couldn't wear perfume. Nobody could wear perfume. But anyway, then she got into school a little longer, and she said, Mom, I think there's some things I could do, that might help your patients. So it started really insidiously. I think the first thing we did was magniluvers, which is magnesium with taurine. That's just amazing stuff,
Yeah, both of those nutrients are really great.
Yeah. So, and then she graduated, she did a residency, ... And then she's like, why don't you start a residency for naturopaths? They need postdoc training. So I started a residency for naturopaths, which was completely 100% self-funded. I just paid them. I guess that's what you're doing, right?
Yeah.
Yeah. So I think it's the only naturopathic rheumatology residency there ever was in the world. So,
Yeah.
And I had some really, really wonderful residents. And and one of my residents turned me on to IFM and the functional medicine thing. And I went through all the courses, and I had their immunology was at that time incredibly weak.
It's okay. We can say that. Things can always improve, and I'm sure they have. So
Right.
yeah.
I'm sure they have. So I wrote them a letter, and I went through a 1-hour lecture and sent them a 20-page typed letter with citations about what was wrong with that 1-hour lecture. I said, you can't do this and give people certification. But anyway, I did talk for them at one of their annual conferences. I edited one of their textbooks on immunology, and I wrote a chapter in it as well. And I didn't get the polite gene, So
Well, you're being the change, right? That's the Gandhi quote, right? You're being the change. You're seeing something, you're pointing that out.
right. So what was that leading to?
Well, it really sounds like
I
sorry.
decided not to do I decided not to take the exam, because so many of the people that were in my little corner of the field, I wouldn't know how to answer the questions. So I decided not to do it, and I just kind of pulled back. And but I did learn a lot, and I learned some truly transformative things at IFM.
Yeah, it's definitely been a great education, and we have a lot of practitioners here who have gone through a lot of the training and certification even. Just kind of curious about kind of how you got into, well, I mean, I guess that's more of an obvious question, but as a rheumatologist now we're dealing with, across the country and the world really, osteoarthritis. If you could talk about osteoarthritis, that's kind of what our
Right.
focuses for today. For anyone that's not familiar, what is the technical definition of osteoarthritis, and then how does it impact people on a day-to-day basis?
Yeah, the impact of osteoarthritis is huge. Our ideas, the concepts of what it is, are changing. And so we used to think it was just a disease of mechanics. And we thought that it wasn't inflammatory because there were no neutrophils in the synovium, or in the synovial fluid, or in the synovial membranes. We thought it was just bad biomechanics. So that's not how we think about it anymore. It's much more than that. Although certainly bad biomechanics plays a role. But there's lots of things that play a role. Obesity, which changes mechanics, and that's a huge problem across the world. Inactivity, stillness turns out to be really bad for you. Overactivity can be bad. We don't work people to death anymore in this country, but I'm sure there are countries where people get worked to death. trauma, particularly as if it crosses a joint or tears a tendon, where you lose the biomechanical integrity. Poor nutrition. I mean, this is as living organisms, we have to put in the things that help us rebuild our bodies, because we're always tearing it down. For instance, bone turns over completely every 10 years. It's not just your hair grows and you cut it off, your skin turns over every month, your bones every 10 years. So if you don't nourish those cells so they can eat while you're sitting still, your joints aren't going to last.
So our osteoarthritis is a degenerative joint disease, and I think what you said about how it's really a disease of inflammation is really timely, because I remember also learning in medical school, yeah, it's bone on bone, but then when you think about sort of OA, osteoarthritis versus rheumatoid arthritis, both of them have at the end of that, suffix of that word itis, which is inflammation. So even in that word, it kind of implies that
Well, I think the
that's a root
word is
cause.
just inaccurate. I think the word is, well, there are many inflammatory components to it, but they didn't know that back when they called it itis.
Mm-hmm,
There's
mm-hmm.
there's many misnomers in medical nomenclature.
How
Um,
does inflammation exactly play a role in the development and progression of osteoarthritis?
it does it through adipokines and cytokines and things like that. So similar to like another rheumatic disease, polymyalgia rheumatica, the inflammatory cells come, they degranulate and they leave. So now, only recently have we started looking at the cytokine profiles in those tissues, and figuring out what roles to play. And mast cells also. Mast cells are resident cells, and you can't test them by doing a blood test and seeing how many mast cells are circulating. You actually have to biopsy the tissue, stain it with a special stain, and then count it. There's not a lot of places that even look at mast cells.
Mm-hmm,
So,
mm-hmm.
but they're like little bombs. They're just full of cytokines. They cause allergy and inflammation, and the inflammation in a joint doesn't look like the inflammation in, say, your gut. But a lot of mast cells live in the gut. They can live in the skin, and they can cause all kinds of problems. But anyway,
Can the mast cells live in the synovial fluid as well, or
I don't think. Well, I
they
don't
they
know.
they may migrate there for sure?
They may migrate and leave. I I actually I know they're implicated somehow in osteoarthritis, and I don't know I've been ill for almost 2 years, so um, I'm kind of out of touch with the current research in mast cells and osteoarthritis, but they are implicated. And since they're resident cells, they probably take up space there, but people don't look for them. You have to test them with CD19 stain or
It's kind
something
of
like.
esoteric. Yeah, it's
It's
hard to really.
extremely esoteric, and there's several different camps of mast cell people. I belong to the Afrin Moldering group,
Mm-hmm.
and then there's the Aiken Milner group, and Milner is not Milner. Aiken is actually near me. He's at the U of M, so he's an hour away. But I'm not in his camp. He's kind of a real allopathic mast cell guy. He says if you don't have an elevated tryptase, you don't have mast cell activation disorder. But if your tryptase is 7.9, he goes, nope, they don't have it. But if you treat them like they do and they get better, what are you going to say? So we
Yeah,
believe,
we're friends with Dr. Afrin, so I guess we're more in that camp, I would say.
yeah. Yeah, we are really in the Afrin camp. So my daughter and I've both presented there, and yeah,
Great, great.
definitely in that camp.
And then what kind of nutritional considerations, you said diet influences inflammation and joint health. What kind of nutritional considerations would you, I guess, consider for someone with osteoarthritis?
Um, Simply put, eat mostly plants, mostly organic. Um, High on the cucurbits and, the greens, and
Yeah, yeah,
uh, but I live in Michigan, and this is meat country. And I think for the first 15 years I was here, I kept telling people, eat plants, and slowly people started going, I actually feel better when I eat more plants. But it's been a hard sell here, really
when you
hard
say
sell.
meats, what about fish or omega-3 pastured, meats and stuff?
Yeah, those are all good. Fish, I mean, you got to be careful where you get them. Uh, I think the 13th worst environmental disaster was in Michigan in
Hmm.
1973, 74, and it put polybrominated biphenyls into the Great Lakes. And so a lot of my patients they fish on the Great Lakes, and they eat the Great Lakes fish, and it's like, no,
So all of the lakes have PCBs or
PBBs, polybrominated,
PBBs? Okay.
yeah, polybrominated biphenol. Yeah,
Okay. Oh,
yeah, it's a hideous story, absolutely hideous story of how it happened. And it was
too bad.
partially due to illiteracy of the people that worked in a chemical factory. But anyway, so I don't recommend eating the fish around here, um, but you got to be careful with salmon that has mercury in it, and I don't
Yeah.
know.
Hard to know what to eat now, with all the toxins in a
It
way.
is. Yeah, it,
Yeah.
it is hard to know what to eat, and you can. But when I was a kid, we had a farm, a kind of a hobby farm, and we had a big garden, 2 acres of garden that was right next to the gravel road getting in. And once a year, we used motor oil on the road. And then we ate the vegetables right next to it.
Hmm.
I mean, yeah, not a good idea.
Yeah. Hindsight is 2020, I guess, on that.
Yeah.
Definitely recommend organic as well. And definitely, I mean, it sounds like there's a lot of different root causes. You mentioned a few things, being sedentary or moving too much, where maybe there's some overuse. Would that be sort of an accurate statement on that?
Yeah, overuse, and just, I mean, who's got perfect biomechanics? I mean,
Okay.
even running, a marathon is probably not a real smart idea, because I've never looked at how marathoners age, but
I do know a lot of marathon runners. Apologies for the people that we know that do run a lot of marathons, but I think at some point, there are some people that are more susceptible to that. Maybe there's some ongoing inflammation in those people, but definitely have seen some people where they need like hip replacements or knee replacements and
right,
things
right.
with
Yeah.
that. The other thing that, we like to talk about too is because of osteoarthritis has some degree of, inflammation and cytokines and, adipokines and things that are affecting the pathogenesis of osteoarthritis. But then also we know that from studies that taking nonsteroidal anti-inflammatory drugs, even though they may increase the person's pain relief and reduce the, pain,
Mhm.
I believe we know that that also can accelerate the development of degenerative joint disease, right? If people are taking long-term NSAIDs.
Yeah, to be honest, I hardly used NSAIDs. And
Yeah,
I think a
yeah.
lot of rheumatologists are in that camp. I mean, how many GI bleeds do you want to see, for instance?
They're in the camp of using the
Not
NSAIDs
using,
or not
not
using NSAIDs.
using.
Okay.
At least where I trained and how I practiced, I do topical Voltaren. People could get stuff over the counter. And then Celebrex and Bextra. I even forget the name of it, Bextra and
Yeah, there were those
Vioxx, the COX-2 inhibitors.
increased heart attack risk and things like
Right.
that.
Yeah, the only reason I guess I shouldn't use names. Celecoxib is still on the market because it isn't a very good COX-2 inhibitor. It's a little safer.
Oh, I mean, I think just anecdotally, I do see less people taking that long term, but there are still people taking it, over the counter, or, sometimes
Right.
it can be more of a long-term thing, sort of
Yeah.
even unintentionally if it's sort of over the counter and needing
Right.
some pain relief. But I'm glad to hear that, maybe that's not as prevalent now.
I don't
And
know. I'm kind of an outlier, I think, especially now since medicine's gotten so politicized and so divided. And
well, you're practicing functional medicine, so we hope to make more mainstream and more accessible, more common.
yeah.
What about other nutritional supplements or herbs, anything like that you have been using
Uh,
in your
luteolin and quercetin,
okay, luteolin
and
clears.
a lot of magnesium. We tell people to try glucosamine or glucosamine with chondroitin, and they take it for 3 months or 6 months. And if it doesn't work, don't waste your money. The problem is a lot of that data just isn't very good. You do a trial for 6 weeks. That's a ridiculous length of trial to do in osteoarthritis, which is a disease that progresses. So my daughter's been using uh, geniculate blocks for knee OA. And they do that in the pain. She's actually a clinician in the pain center at OHSU.
Okay.
And she says some patients just won't walk because their knee OA is so bad. And these geniculate blocks take the pain away. They'll walk again. And once you start walking, the cartilage only gets hydrated and nourished if you walk, because it's a little sponge in there. You got to apply that pressure. So if you're not applying the pressure, then you don't get the perfusion of nutrients into the cartilage. And it's vascular in a very small part around the rim. And so you have to push it in. And she had a patient that was ready to go to a nursing home. They did a geniculate box. She walked again. So,
Wow. It's
it's one
huge.
patient, but they ought to, I don't know if you do geniculate blocks, but they
No,
can't.
no, is it common? I don't know that familiar with that.
I don't know. I don't know how common it is, but she's found it incredibly helpful.
That's great. And then, like you said, that's a huge point too. The movement is huge to stimulate the vascular system
Yeah.
and the cartilage. That's another huge point too.
Yeah. Let's see if I've gone through kind of the questions. Yeah.
I think manual therapies would be another, what is the role of physical therapy, chiropractic care, or osteopathic manipulative therapies?
I am not terribly fond of manipulation alone as a therapy. I think in conjunction with movement, and this is coming from my dancer part, right? That moving should be healing, that you can learn to move in a way that nourishes you. That said, I can tell you that's hard. That's really hard. I happen to have done a lot of work before I went to medical school in movement analysis, all kinds of movement analysis from a dancer's standpoint, and an expression, and that like, just as you look at me, this shoulder is kind of funny, right? I mean, and it moves weird. I mean, it was moved really different than my other shoulder, right? This has been pretty massively operated on, so I fell and tore it apart. And the
Okay.
tendons started popping off. But I've learned to move it again, and I mean it just had a horrible trauma to it. So, and then there's some other underlying things that go into causing osteoarthritis, and a big one is hypermobility, joint hypermobility, because those joints, they just don't stay in the exactly, they kind of sublux, maybe not dislocate, but they slide on parts of the rims of things where they shouldn't be, and then those rims wear out. I tell all my patients, go 70% of where you can go.
Okay, that's really good advice.
Don't explore the edges. And as a ballet dancer and as a gymnast, you spend your days exploring the edges of where you can go.
That's where the injuries happen more, at the edges. Yeah.
Right. Yeah.
And tying it back to osteoarthritis, we see that, the culture is often very competitive. Like, okay, if we can run a 10-minute mile, now I want to run a 9-minute mile. I want to run an 8-minute mile. I want to beat this other person, I want to place a little higher. And this is something that the mindset shift is required to really, protect the joints. And in addition to hopefully enjoying the sport of choice better.
Yeah.
What are some of
you can override it with the pleasure of winning, of how you would do it if you have that goal to win. You can override your body sense. And
so I think what you're saying is that short-term gains may lead to long-term pains. Is that sort of a potential thing if someone is trying to compete all the time and overusing the body?
Yeah.
What about acupuncture? Have you had experience either referring or personally with acupuncture and maybe mind body techniques too, like meditation? How do they help with pain management with arthritis?
Acupuncture is pretty incredible, particularly electroacupuncture. But I think I've had personally a lot of acupuncture, and for a whole variety of reasons, not for the OA, but for other reasons. I've had acupuncture, and I'm definitely a fan. I think, I don't know, I can't talk in detail about the techniques, but I think balancing the meridians and putting wavelengths of electricity in that are conformed is right. I think they're really personally helpful. Acupuncture is not licensed in the state of Michigan. Insurance doesn't pay for it. And so it's really for rich people, which is really, really unfortunate. And I never learned acupuncture, so.
Yeah, acupuncture licensing, I think, varies quite a bit from state to state. And there's certain states where doctors can be acupuncturists. There's other states where only acupuncturists that have gone to acupuncture school can be acupuncturists. It's kind of an interesting landscape there. I do have a little bit of medical acupuncture training in Maryland here. It's sort of a mixed kind of field where we can work together. In our clinic, we work together. We have licensed acupuncturists and who do most of our, acupuncture. But I agree, it's really great. And there's a study by Dr. Berman here in Maryland that talks about knee osteoarthritis and how acupuncture is effective for that. I think that was back in the early 2000s. He did that study. That's a pretty well-known one. Well, osteoarthritis really, it seems like, just to recap, there's a bunch of, points here, but going into testing, I do want to talk a little bit about testing in terms of functional medicine. I don't think we can get away from the functional medicine topic without talking about testing. Do you think about testing for people with OA? Do you do testing, like functional testing, or what kind of lab analyses or other analyses are you looking at for people with OA?
I'm going to back up because we skipped over something that I think is really important.
And let's not skip it. Yeah.
Let's not skip it. Long before testing, history. So getting a history, that to me, that was, going through medical school and residency and fellowship. were, I just didn't get the whole I mean, we got the history of the presenting illness and the things that led up to it, and then, dot, dot, dot. But the functional medicine history is just so, so important, and it gives you, I mean, you're all functional medicine people. So did your parents love each other? Did you have enough to eat when you were a kid? Was there violence in your
That's
home?
huge. Yeah, it's huge.
These things are huge. And so when you look at somebody who's had the kind of traumas that like how much, how am I going to organize this? So for me, as a rheumatologist, history and physical have been, a whole lot of it. But once I met the functional medicine history, it's like, this is so important, the functional medicine history. And the next thing, of course, is physical exam. So when somebody comes in with a sore knee, you don't look at their knee and send them home. I had all my patients undress, and I would say just strip to what you would wear to the beach. And I'd watch them do it. I didn't have the MA give them a gown, go in a room. I would say it's part of the physical exam. You learn a lot watching people dress and undress,
Oh, that's nice. That's nice. You actually watching them undress, and you can actually see how they do that, and that can tell you
Oh
about
yeah, like how
their
they take their
posture.
shoes
And
off. Oh,
yeah,
seriously, you
yeah,
got OA in your left hip. Uh, I mean, I had more than half the diagnosis done watching them undress.
that's really, yeah, it's because it's a functional movement.
And I had a long hallway in my office, so I'd walk them up and down the hall. I'd walk behind them, I'd walk beside them, and I go, oh, a little varus in that knee. That's not hitting on the right places. Or so there's history, observation, and then the physical exam. So I think one of the things, even in DO school, we never learned to do a comprehensive joint exam, which is mind-boggling to
That's
me.
so surprising, especially in DO school. Wow.
Yeah, it's very surprising. But I had a patient who became a, a co-presenter with me. She's an internist, and uh, she rotated with me long after she'd become an internist, and we did some videos together and gave some talks. And she I taught her how to examine a knee to see if it was hot. And she was teaching OMM at Michigan State. She had no idea.
Ah, I see what you're saying. Got it.
She had no idea. So I'm going to demonstrate it on my elbow. You have a knee, and you run the volar part of your wrist up the shin and onto the top of the thigh like this. If the knee is the same temperature as the shin, it's hot. And there may be more than osteoarthritis in that knee.
If the knee is the same temperature, you're saying the knee should be a cooler
Colder.
temperature?
The
Colder.
knee should be
Okay.
cold. The elbow should be cold. The shoulders should be cold. I mean, but
Oh, okay.
yeah, those big hips aren't, because they typically have a lot of fat on them, and you're pretty far from the joint when you're over the.
I'll have to check out my own joint now after
No,
this call here.
it's really easy. I mean, I think I can get my leg up high enough. Yeah, you just I'll do it with this one. You go up the shin onto the knee.
Okay.
My knee is much colder. See that? You just go
Yeah,
up.
my knee seems colder, so I think at least for right now, if I probably hopefully don't have osteoarthritis. So
No, you don't. And you can get all kinds of other complications. You can get calcium pyrophosphate deposition disease in an OA knee, and that'll be hot. And that's again, if it's the same temperature, it's hot. And
that's good. That's
low
good.
grade inflammatory things. So I didn't want to miss that.
That's good.
Okay,
Yeah.
let's talk about imaging. So I wasn't heavy on imaging. I didn't, unlike many of my colleagues in this town who X-ray every joint every year because they have their own X-ray machines, right? I didn't do that because I don't think you learn that much. Although I they can definitely be helpful, but unless people really push, like, do you think I need an X-ray? I get X-rays, but you don't need to go to that immediately if it's mild and you're not suspecting, a bone malignancy or, calcium pyrophosphate deposition disease or some other benign tumor in the bone or,
And you can get a lot from the history and physical, it sounds like.
you can get a lot from history and physical. And sometimes the X-rays aren't even that helpful. Like you may have a patient with bone on bone in both compartments and a varus deformity and a little limp, and they go, I don't have that much pain. Well, that's a really bad knee. I think you do your disservice to your patients telling them they got a really bad knee when they're living with it perfectly well. It doesn't have to be bad. I mean, that's actually one of my board questions almost every year. Patient has bone on bone, bicompartmental knee OA. What do you do? And they give you options like physical therapy, knee replacement, and whatever. And the answer's, PT at the most. You don't replace a joint just because it looks ugly. If they're
If they're
functional,
functioning, right, functioning
if they're
okay, then
functioning well, there's not an advantage because, as you know, joint replacements fail.
yeah, there can be side effects or they're not working as well as they would like always.
Yeah. Yeah.
When do you decide? Yeah, when that's probably something to talk about. When do you decide for your patient with osteoarthritis, hey, we've tried all these things. When would you recommend joint replacement?
It's interesting. I'll just give you a little example. I have a patient, I think he's 92 now. He has he had a little alpaca farm, some big dogs, and a retired math professor. And he had bone on both his knees, and he had trouble getting out of a chair, and he was getting older, and he thought, I'd like to be more active. And so I said, well, they take a saw and cut off the bones and put prostheses there, and you got a recovery period. I said, he goes, well, my activity level's gone down so much. And so I sent him to the surgeon, and he looked at it, looked at the recovery, and he said, how long am I going to live? And I don't need to run around the farm anymore. And he opted for a more sedentary lifestyle than a knee replacement. And that was probably a wise choice. I had another patient who had a lot of trouble walking. He had a bad knee, and he kind of suddenly had this really horrible problem walking on the leg with the bad knee. And I think his primary care sent him to the orthopedic surgeon. They replaced the knee. And then he came to me and he goes, this knee replacement's a disaster. I can't get off the walker. I can't walk. And I looked at him walking and I said, oh, you snapped your vastus lateralis right off the trochanter.
Ooh.
And that gives a, what do you call, Trendelenburg gait, right? Do you know
Yeah.
what that is?
Yeah.
I don't know if I can demonstrate it here, but yeah, it gives you a Trendelenburg gait. And he came in his walker with a Trendelenburg gait, and I said, you didn't need a knee replacement. Now, reattaching the vastus lateralis to the greater trochanter is also fraught with problems.
I'm
I've
sorry, why didn't he need a knee replacement? Because it was not a knee issue, it was something else.
Yeah, it was his hip. He
Hmm,
couldn't
hmm.
walk because he ripped his
Oh,
vastus
because of
lateral.
that.
Yeah,
Hmm.
he goes, look, I still can't walk. It wasn't the knee,
Okay.
it was the
It was
hip.
something
And that
else,
was an
yeah.
orthopedic surgeon, and they train orthopedic surgeons to at least examine the joint above and below. But this guy didn't look at the joint above.
That seems rare. Like I haven't really seen that kind of case before. Hopefully it's rare.
I've, I think I think I've seen it 3 times. I think it is pretty rare, but you at least have to look at the joint above and the joint below,
Mm-hmm.
at least.
Definitely. No, that's a good. It's all connected, right? The bones, the all the joints, the fascia.
Yeah.
Um, Carla, thank you so much for coming on today. I think we want to talk about just kind of in closing because we covered quite a bit of things today, including South Indian dance. So we appreciate you talking some about that. What is one thing you wish everyone knew about taking a root cause approach to osteoarthritis? Like kind of like a take home point for them.
If you don't look at the root cause, you're going to be a orthopedic surgeon. You're going to think you can just fix stuff. I mean, you really have to look at the whole person. You have to look at the whole person.
And it sounds like the biomechanics is a big part of it because if even a slight deviation of what would be considered optimal, it might over years
Yeah.
be contributing
Yeah.
to that.
Biomechanics is huge. Another one of my loathed movement uh, techniques is yoga. And I think that's really dangerous because you're just going too far. Um, the there's a ton of literature on Tai Chi in terms of longevity of what helps. And there's a relatively new technique called gyrotonic that I think is really wonderful. It's not it's not like going to the gym. It's not two-dimensional repetitive, but gyrotonic is a pretty amazing technique. And Tai Chi, that's what has the most literature for movement techniques because, doing these studies, you don't make any money out of figuring out what technique is better than any other, right? And you don't do it long enough, and then you don't do the follow-up long enough to see what people could integrate into their lives and what's a blip of, 6 weeks or 8 months or even a year in a lifetime. It's not much. So you have to give these people alternatives for something they can incorporate into their lives pretty frequently. So
Well, I think it's the same with running, ballet, gymnastics, yoga, tai chi. I mean, anything could be taken to the extreme, and the extreme is probably relatively extreme for a different person. So having that person's health and their body taken into account in an individual way is
right.
probably going to be safer. Like I know we can think about people that take Tai Chi classes or instruction, yoga therapy. It's probably different ways to
Yeah.
make it safer for people. So
Yeah,
I
yoga.
agree. I think moderation.
There are some very good yoga therapy things. I shouldn't have been so harsh on yoga. But
Well, no,
some
I mean, I think
ones,
anything has the potential for injury for sure.
yeah. Yeah,
But
anything. But yeah. So there were just two other things. One was just a little comment about ultrasound. I don't know if you do ultrasound in your clinic. Um,
not currently, but yes, let's talk about ultrasound.
yeah, you really overdiagnose stuff. And if you're doing ultrasound guided, whatever, it isn't going to show to the cartilage. So the orthopedic surgeons will say, you do these ultrasound guided injections to the knee, either with steroids or viscosupplementation, and you just pick the cartilage apart.
So you're not a fan of hyaluronic acid or
Oh
steroid
God,
injections,
no,
anything like that,
no, nope. I
because
don't
it
know.
actually damages the cartilage when
Right,
you
the
go in.
needle. Yeah.
the needle itself, even though.
And there's no good evidence that it works. There might be a subset of it, there might be a subset of patients in which it works, but, apitherapy maybe is good.
Okay. What
So, yeah,
can we just clarify for the listeners, apitherapy? What do you mean by
bee
apitherapy?
stings.
Yeah. Okay. Like actually just getting stung by a bee, or actually
No, you actually
apitherapy?
put the bee on the knee.
Okay. No.
There's actually some literature for that, and there's also some literature for leeches.
We just met a beekeeper at a farm, so we'll have to ask her or him about that. Ask them about that. I think the other question I have now that we're talking about injections is, what is your view of going to get into the regenerative question here, PRP, stem cells, exosomes? Is there any role of that for any of those things for OA?
I've done a fair amount of it, and I've had it done to myself. Uh, and after I don't know how long I did it, couple of years. And I don't I, I think maybe there's a better way. I don't know. I bought a very expensive machine and I used it a fair amount, and I didn't see enough change that made me want to keep doing it. And
So yeah.
steroids are pretty overused. Steroids are overused in osteoarthritis, and you have to be careful with them.
Hmm.
So, and
A lot
again,
of side effects. A lot of side effects.
yeah, and again, you're picking the cartilage apart to put it in.
So if there was one thing that you could really say, and maybe there's more than one thing, but let's just say, one what your top, favorite thing you would think about for osteoarthritis, what would that be in terms of treatment,
Eat well, move well.
Love it. Simple and really good. Thank you. Well, thank you, Dr. Guggenheim, for coming on today. Carla, part of our mission at CIH here is to make integrative healthcare more accessible and focusing on the small steps that we can take to improve our health. So we'd love to hear from you personally. What is one thing under $20 that you feel has transformed your own health? It
Walking,
also doesn't have to cost money. So that's, we're not
walking,
talking about Five Below. Okay,
walking in a
walking,
pair of
walking.
flat shoes with a wide toe box.
Okay, I think we can talk about brands. Do you have a specific brand there that you like, or?
Um, I oh God, what are my latest shoes? Uh, it's not the Asics. I have quite a few shoes.
Flat meaning rubberized is
Yeah,
fine, like the
sneakers.
cushiony sneakers. Okay,
Sneakers
okay.
with a little bit of a rocker, and
Yeah.
uh you know, it should fit your foot really well. It should be comfortable when you put it on and walk for 5 minutes in the shoe store.
Okay.
And you should never wear high heels or pointed toe shoes. Those disrupt the biomechanics of the gait massively.
So
Mm,
don't wear them at cocktail parties, no ballet shoes, nothing like that.
no point shoes,
Okay.
and no pointy toe, high heeled shoes, no things. I mean, look at the shape of your foot and buy a shoe that fits it. Like I've got a whole bunch of OA in my foot, and it's a really wide foot. It got all kinds of orthopedic problems, but I have to buy a shoe that I can put my foot on top of the shoe and I can see the shoe all the way around my foot.
It makes common sense to not shove a shoe into someone's foot that doesn't fit. But I guess there's, people have stylistic concerns and different things. But yeah, it's not good for the
Oh,
biomechanics, though, it sounds like,
it's
at all.
horrible. That was my research in biomechanics, was the biomechanics of point shoes. And
Yeah.
those are terrible, but high-heeled shoes are equally as bad, and people wear them for a lot longer. Ballet dancers don't wear them that long in a day. They do super stupid things with them, like standing on the tips of the toes, but even walking around all day in high-heeled shoes is lunacy.
And pointy shoes plus a combination of that and alcohol is probably not a good idea either.
Oh, alcohol is never a good idea. It's poison.
But in terms of the balance of, people falling after,
Oh, right. I mean,
things, yeah.
and it's true about OA in general. I mean, a lot of people die of falling.
Mm-hmm.
Older people die of falling. So you
So,
combine that with bad biomechanics, you fall more. If you combine it with bad biomechanics and non-ergonomic shoes, you're gonna fall more. And then if you add the alcohol, you know.
okay, so no alcohol, eat well, move well, don't wear pointy shoes, reduce inflammation, and listen to Dr. Carla here. So thank you so much for coming on today. Send some gratitude to you for coming, today on this call. It's really been a pleasure, and we really are really appreciative. I know the listeners are really appreciative of your wisdom, talking about arthritis and your life, and just want to wish you well.
Thank you so much. I've really looked forward to this. This was really a really nice, nice for me to be able to do this. Thank you so much for the opportunity. I really, really appreciate it.
Thank you, Carla.
Yeah.
Thank you so much for joining us today for this episode of the Capital Integrative Health Podcast. A quick reminder that the information we share on this podcast is meant for educational and informational purposes only. It's not a substitute for professional medical advice, diagnosis, or treatment. We highly recommend that you speak to a qualified healthcare provider before making any medical or healthcare decisions. If you enjoyed this episode, please take a few moments to subscribe and leave us a review. Your reviews help us reach more people and continue to offer innovative insights and information to better optimize your health and wellness.